Morning, Paula. I just hit permission to record for you. Good
Hi,
morning.
thank you so very much. How are you?
Good. How are you?
I'm doing great, thank
Yes,
you.
I haven't seen you for.
I'm trying to sync something up here, so give me a second.
minute.
Okay, I just want to make sure that I'm recording.
Okay.
You know what? I'm going to jump out and jump back in.
Okay.
I can't tell if I'm recording, so let me jump out and jump back in.
Okay.
Okay, thanks so much.
Yep.
Hey, Tammy, it's not, can I just sent the request again.
Okay.
Hey, all right, let me do that one more time.
Let me allow to record local files. So it should
Okay,
pop up.
this is allows you, so give me a second, because for some reason it's not recording. Well, there it is. I think it's recording.
Yeah. I'm recording too. So
Yeah, but I got to turn
as
it
a
around for
backup.
you. Okay,
Oh,
awesome.
okay.
Yeah, awesome. Thanks. I think it's recording. It's just hard to tell, but I guess I'll find out the hard way.
Oh no. You
All
know,
right.
one time I did this and I didn't hit the record button and I had to ask Associated Press send it back to me.
Oh my gosh.
I was
Yeah,
like, please guys.
that's
I'm like,
happened
"Oh,
to me
no
too.
problem."
Okay. Got it. Okay, let me jump off for a second. Thanks so much for that. I
Sure.
appreciate it. See ya.
Thanks for joining today.
What's the protocol for asking questions?
If you could put them in the chat, that'd be great.
Okay, great.
And then
Thank you so much.
I'll call just so I make sure I don't miss any.
Okay,
I'll go through the chat
awesome.
so you can
Thanks.
answer. Thank you. Hello, Dr. Fishbain. I see you're
Hello.
muted. There we go.
Yeah, hello.
We have just a couple minutes.
No problem.
Tammy, would you mind giving us permission to record?
Sure. Hi, Kate.
Thank you so much. Good morning.
Thanks for joining. Pull you up here. There you go. Got it?
Got it. Thank you.
Awesome. Okay, we're at 11. Let's wait one more minute. Make sure we get folks. Let me give WXYZ permission to record. Okay. We're good. If anybody else would like permission to record themselves, please let me know in the chat.
Yes, please.
Hi
Darren,
there. Yep.
I'm under reporter. I don't know. I'm trying to change my, I can rename it here.
Oh, here we go.
Thank you.
You're welcome. Okay, it's 11:01. Thank you everybody for joining us. This is the Beaumont COVID update. Today we have Dr. Joel Fishbain. He's the medical director for infection prevention at Beaumont Hospital, Grosse Pointe. Dr. Fishbain, thank you for joining us today.
You're welcome, and thank you all for joining us. We'll run through this pretty quickly, and then I'll be happy to take some questions. Typically, everybody wants to know what our current case admission rate is. We, as of this morning, have 64 inpatients with COVID, and also a lot of people like to know about how many cases of COVID we've had after vaccination. And currently, our experts who are tracking this in the Beaumont system have suggested only 0.06% of our COVID cases are considered vaccine failures. So vaccination is still very, very good. So our numbers are nice and low, but they're going up slowly. Compared to last year, obviously, we're doing better. However, with the Delta variant in the country, this is probably going to change. And if you want to start with the map, that would be great. We can use that as a talking point. Thank you, Tammy.
Mhm.
So the CDC has been tracking this. Of course, most of you have probably seen this. The salient feature of this one is that the red represents a significant percentage of patients with COVID, as well as an increasing rate of COVID positivity. Partially good news story is Michigan has been not hit as hard. You can see that Southeast Michigan is creeping up with Northern Ohio. So this is a little bit concerning for the entire country, and it could be another disaster for Michigan if we continue to rise in our cases and this continues to increase. One of the things to talk about today would be the idea about vaccination success and failure. So as you know, when you're looking at this map, 83% of the cases in the United States are now the Delta variant. If you have any more questions about that variant, we can talk later during the question and answer period, but we know that this is the predominant strain in the United States. It is highly contagious. We are seeing a huge increase, mostly because of the Delta variant. As I have already said, 83% of cases are the Delta variant. You may be aware recently about the vaccination failure, so to speak, at the MMWR report at the end of July about the gathering at a city in Massachusetts. They did a very nice study where they looked at the number of cases, symptoms, the positivity rate, and they even looked at the amount of genetic material in the patients who had a positive test to try to compare if vaccination had an impact. The greatest concern is that 76% of the individuals who were vaccinated had symptoms that met a COVID definition and tested positive for COVID. They were mild, but they were still positive. They suggested on their data that the amount of genetic material being excreted in the swab samples was about equal to those who were unvaccinated. One thing I have to say, though, is that that does not prove that all of those particles are actually live virus. So there is still more to do, and even in some of their disclaimers, they did talk about the fact that they don't know what the microbiologic implication is of that. But it is concerning. I think it's drawn some attention. Does this mean the vaccine does not work? Well, no, the vaccine still works, but the concern from the CDC with their release last month of recommendations for universal masking, even if you've been vaccinated in high transmission areas, is the idea that the vaccine likely protects you from getting sick. It certainly protects you from getting severely sick and ending up in the hospital. But can you spread it? And the concern is it is possible that even if you have a transient infection with a short period of time of viral replication and then resolution, you could, in theory, transmit that. I think there's more data that needs to come out and more information before we make that leap. But clearly, the Massachusetts example is concerning. So the CDC came out with a change, which I think has upset people, suggesting that, well, if the vaccine doesn't work, why do we get it? Why am I masking? Let's reiterate. The vaccine works and prevents the vast majority of people from becoming severely ill, getting admitted, and dying. So the vaccine is effective. Does the vaccine prevent transmission? More to follow. Do we have historical information and precedents for vaccines not preventing complete infection with possible transmission? And absolutely, that is known for influenza. And while pertussis is a bacteria, the vaccine doesn't keep you from colonization and spreading. It just prevents pertussis symptoms. So we have good precedents for vaccines that prevent infection and disease, but does not necessarily prevent transmission or transient carriage of that virus. So not really a surprise, but very concerning. So we are still pushing for vaccination. My gravest concern is, where did the Delta come from? The Delta variant and the other variants came from continued replication of the virus and infection in the community. Variants and mutations are bound to occur. I'm concerned that the next variant might escape previous immunity and might escape vaccination. That's why we have to vaccinate everybody as quickly as we can, try to prevent any transmission. And I think individuals should probably consider going back to universal masking when they're going to stores or when they're gathering in large groups indoors. If it helps prevent spread, then it helps prevents replication of the virus and would help prevent any further infections with Delta variant or any future variant. And that's why we need to get on top of this right now. I think I can stop there unless Tammy wanted me to address anything else before we go to questions and answers.
Thank you, Dr. Fishbain. I think there needs to be a clarification. When you said the percentage of people who were vaccinated but are testing positive for COVID, you said that it was 0.06%. How many people do we currently have hospitalized that had breakthrough cases?
As of this morning, 3 individuals were in the hospital who we would call vaccine failure.
And that's out of a total of across the system?
64.
Okay, thank you for that clarification. If anybody has any questions, please feel free either to, go ahead.
Hey,
Who's this?
Darren Cunningham, Channel 7.
Hi, Darren.
Hey, question. So back that map, I didn't see like a key or a legend as far as the colors. Obviously, red was bad, but the yellow, is that like what are the levels there? You had red, yellow, blue.
Sure. If Tammy can put it up and scroll down to the descriptions of what that means, sure, we can go through that. That's fine.
Mhm.
Because you mentioned southeast.
See right here. High is red, orange
Oh.
is substantial, yellow moderate. Blue
Yeah,
low.
and if you just want to go ahead, the numbers that they represent, if you want to scroll down.
Whoop,
I
here,
see.
I'll go ahead and take a picture.
Thank you.
And we can scroll down here.
So this is, if you just want any detail, this is sort of interesting. If you notice that the red is the level of community transmission, red is high. And if you look at the percentage points different since 7 days ago, that represents, rounding up, 16% increase in those areas in the last 7 days. And if you want to scroll down some more absolute numbers, if you like that kind of thing, what they're saying is, remember, you normalize data background, whether it's persons, person days, whatever, you usually normalize the data. So they usually use 100,000 people. So there are more than 100 cases per 100,000 people in the past 7 days to make you red. The other concerning part is that the percentage of positive tests is much greater than 10% or equal to get you into that rate. Right now, obviously, we're running 3 to 5%, depending on what county or what state level you're looking at. Anything above 10%, which means 1 in 10 people with symptoms showing up for testing is going to be positive, and that is gravely concerning. So this is what the blue, yellow, orange, and red represent as far as numbers, if you like numbers.
Not a fan of numbers, but thanks, Doc. I'm a journalist.
High bad, low good.
Hey, Tammy, I have 2
Paula.
questions in the chat.
Yes, Paula Tutman, WDIV, go ahead.
Okay, I'll go ahead and ask. I have 2 questions. Thanks. Hi, doctor.
Hello.
So you called it a vaccine failure. Is that different than a breakthrough? If so, how? That's the first question. Then there's a second.
Semantics, it depends on how you want to define it. If you want to be picky, you could talk about the previous data that the CDC has a great table when they're reviewing their vaccine effectiveness and all of the current studies published. There's a great table from the CDC that shows that last year, when the vaccines were being studied, the percent of people who tested positive with no symptoms was 10 to 20%. So 80 to 90% vaccine efficacy at preventing no symptom infection COVID. Now, if you look at the Massachusetts, you're talking about a much higher rate. So that goes to show you what the Delta does. So the semantics would be how many patients have no symptoms but test positive versus have symptoms and test positive versus in the hospital. If you want to attach a label to that, whether it's breakthrough or failure, go ahead. To me, it's all the same.
Gotcha.
If you wanted to break it down precisely, you'd have to say how many patients test positive with no symptoms, and if you want to call that asymptomatic COVID, fine. The vaccine used to be 80 to 90% effective at preventing that, but the Massachusetts article would suggest otherwise with the Delta variant. And then if you want to say symptomatic cases, then that's much smaller, but still significant. So kind of depends on how you want to label it.
Okay, so let me follow up for clarification on that, and then I have my second question. So in terms of the patients you currently have in your hospital who are vaccinated, so they're obviously hospitalized, they're showing symptoms and they're showing signs of illness. Do they have any other conditions? Do they have any other underlying conditions, or it's just breakthrough, failure, whatever?
Actually, I don't really have the information on individual patients, nor would I really go through that, but we know that there's a group of individuals at risk for vaccine failure. Why don't we just use that term, however you want to couch it. So vaccine failure is you're at risk if you get vaccinated, if you have an immunocompromising condition, if you're a transplant patient, the elderly, you're receiving medications that would impact the immune system. So there are certain predictors of who might fail a vaccine. I can't tell you of the three that are admitted where they would fall into that.
Gotcha. Okay, thank you. And then also, when you compare the rate of transmission today to February or March of last year, for instance, what are we looking at in terms of community spread in the next month or two? Because we're getting ready to have a change in climate. Kids are going to be back in schools. People have COVID fatigue. I have no idea why people are bothered by getting a booster shot, but they are, and wearing a mask. All of these things go into with this new, more transmissible, more virulent variant of this virus. What do you think we're looking at?
A potential disaster. I think the potential exists for a huge disaster, and what do you want to call it? Surge 4, Surge 5? I mean, I've sort of lost count, but if you had a large group of individuals who have not had COVID or did not know if they had COVID and they are susceptible, and you put them in a situation that allows the Delta variant to be transmissible, you could have another explosion of cases. I don't know how many people out there had it and didn't know it. I don't think we're doing the significant sero surveys, but regardless of that, I think the potential exists for tremendous spread and increased cases, especially if you look at under 12-year-olds who are not eligible for the vaccine. Kids, it's very difficult probably to keep their masks on. We can do everything we want, but as with many other viruses, the kids can bring it home. And then obviously, if you've got family members not vaccinated or family members who are vaccine failures, but you just don't know that, there could be a marked increase in cases. And don't forget the high risk categories of obesity, diabetes, age, et cetera. So the potential exists. And that's the concern.
Thank you so
Yeah.
much.
Thank you, Paula. Thank you, Dr. Fishbain. Chris Hall, you have your hand raised. You'd like to unmute and ask your question?
I would, thank you. Can you guys hear me okay?
Yes, we can. Chris Hall with the Free
Okay.
Press.
Yes, thank you. I was just wondering, in terms of the 3 cases, do you have some details in terms of how sick the patients are, those 3 particular cases, and the type of vaccine they may have received? And you were talking about another explosion of cases. Are you assuming that this would be with unvaccinated people or children, or are you talking vaccinated people as well in terms of this explosion of cases that could happen in the future?
Yeah,
Thank you.
Yeah, sure. I don't have any information on the 3 cases. I'm sorry, as far as details. The answer to the second question is, before the Massachusetts article, I would tell you that I am extremely concerned about the unvaccinated. But now with the Massachusetts experience, I'm concerned about the vaccinated getting mild disease and continuing to spread it. So I think you add that to the background transmission rate. Maybe that is why The Delta variant is 225 times more likely to be infectious, contagious, from what the CDC is reporting based on the numbers. So if you just had unvaccinated, maybe getting sick and spreading it, that's one thing. But now you throw in the vaccinated who could potentially transiently spread it more, that's a concern. I'm not as concerned about the vaccinated individuals getting sick. It's pretty clear they don't. It's more concerning that they may spread it to unvaccinated individuals. So, kids tend not to get sick or as sick. They certainly can spread it at home. What if grandma and grandpa's on chemotherapy and had the vaccine and it failed? What if mom and dad have a transplant? Those are the things that worry me. So we have to address it now and try to put in the best mitigating factors we can to prevent that kind of spread and a resurgence, or like I said, is this surge number 5? I completely lost count, but that's my concern.
Thank you.
Thank you, Dr. Fishbain. Kim Russell from Channel 7, you had your hand up.
Yes, thanks, Dr. Fishbain. I'm hearing from doctors' offices that are getting inundated with people wanting letters, excusing them so they don't have to get the vaccine if their employer is requiring it. What's your message for the public about what is an excuse and some of the misconceptions? For example, I'm hearing OBGYN offices are getting a lot of people who are worried about fertility problems. What's your message to people who are trying to get these letters about what is an acceptable excuse and what they should know?
Well, that's a good one. So on the positive note, let's start with the beginning. Have we ever come this far in science so quickly to develop a safe and effective vaccine? And the answer is no. This has been done well. It's been done quickly based on our current abilities and techniques, and it appears to be a safe vaccine. Part number 2 is please stay off social media. Okay, I'm not a big fan of social media experts and rumor and conjecture. The data suggests it's a very safe vaccine. Do we have all of the long-term data that we would love? No, we're not going to get that because I don't think that we could afford to wait 2, 3, 4, 5 years to say, okay, it was a 5-year safe vaccine, now let's give it. We don't have the luxury, and we need to bring this out. People need to get the vaccine. It is safe, it is effective. I don't have any comments about exclusionary documentation, get out of jail free cards. I don't have any comment to that. I just want to encourage people and hope that they trust the science and move forward, get the vaccine, go back to work. If you were a 55-year-old individual who had diabetes, morbid obesity, hypertension, working in an area where there could be COVID spread and you don't want to get the vaccine, it's a little hard to say, told you so when you're on a ventilator and sick. I mean, I don't behave like that. I'm just saying, once you get sick, it's a little bit late. It's really better to, move forward and get the vaccine.
What I'm hearing from you is that a lot of the things that people might think would be excuses typically for them to get out of any sort of thing might actually be a reason for them to get the vaccine.
I guess, all I can say is, get the vaccine. It is safe, it is effective, and personal decisions are personal decisions, but I don't have any advice for practitioners, physicians, nurse practitioners, et cetera, on writing those letters and how to approach it. That's a tough one. I'm hoping that the medical community all stands together and says, you need your vaccine.
I'm pushy picking in. It's Paul again. To Kim's question, though, who medically should not get the vaccine?
Unless you're allergic to one of the components, I actually haven't seen any significant reasons not to. In the first place, it is not a live virus vaccine. So we do recommend avoiding live virus vaccines in people whose immune system would not be able to handle it. This is not a live virus vaccine. So that exclusion would not apply. As far as not getting it, I think the list is pretty small. I think you'd have to prove that you have an allergy to one of the components. There is a component in the manufacturing process that can cause allergic reactions. Those are pretty rare. Hopefully you've discovered that because that component is in a lot of our food products. makeups, et cetera. So if you had an unusual allergy, it should have been picked up by now for that particular component. But unless you have a known allergic reaction to a component of the vaccine, I don't really have any good exclusions for people.
Thank you, Dr. Fishbain. Thank you. Robin Erb, I saw your hand up. If you'd like to go ahead and ask your question.
Morning. Thanks for doing this. Robin from Bridge, Michigan. Question about the vaccine supply. Obviously, the question is no longer do you have enough, but I'm wondering about the numbers that you have there at Beaumont. Are you finding that you have them expiring now? If so, have you been able to redistribute them? Just talk to me a little bit about your supply. And thanks again.
Yeah, no problem. I wish I could answer that. That's a pharmacy logistics issue. I actually am not part of that system, so I couldn't answer that question even if I wanted to.
Okay, fair enough. I'll follow up, Tammy.
Thank you. I don't see any other hands up.
Tammy, can I ask one more question, please?
Sure, Paula, go ahead.
Let's talk about the booster. I know in Israel, they've started administering a booster. Some people may decide, well, I want that booster prophylactically. What are your thoughts on going back to get a third shot?
Yeah, I think this is a fascinating time in medicine because you start a process and you're following it and tracking it, and things change on a daily, weekly, monthly basis. So until the FDA and the CDC starts to see that there is a relationship between antibodies or immunity to the vaccine and need for a booster, I think we have to stay at this point in time. The longevity of the vaccine is good. We don't seem to need a booster, and that could change tomorrow. So we just have to keep tracking the data to make sure that a booster is or is not necessary. Once a booster appears to be a necessary part of this process, then we're going to need to move on with boosters. Do I think it's harmful? No. Do I think people are going to have reactions as we boost the immune system? Yes. Anybody who knows about getting their second dose of one of the RNA-based vaccines, you can have a 1 to 2 day symptomatic event showing how robust your immune response is. I expect those to continue with boosters. But until they suggest that there's a huge amount of breakthrough and that a booster is the answer, I would not recommend running out and trying to get one on your own because we don't know what's going to happen. That needs to be driven by science and the epidemiology of infections. So here is my thought. If we continue to have Delta variant and a huge number of cases occur in the United States and we don't knock this down now, we could very easily get a variant that is not covered by the vaccine. They'd have to completely retool the vaccine and re-administer a whole new one to try to keep up with the changes of the virus. So now is the time to get the vaccine. Let's not worry about the boosters yet, but watch the science, watch the recommendations, and let's see where we go. But yes, we've already had people say, I kind of want a booster, it really worries me. What if you have a reaction that we weren't expecting? So I think you have to follow the FDA and the CDC guidelines and recommendations, and they will continue to monitor the science. Israel is doing the same thing. I don't really have a good explanation for what Israel is experiencing, except maybe it proves that the vaccine last year for that circulating variant isn't as well covered by the Delta, more to follow. But I think this goes to show you, this is what happens when you let the virus go unstopped and continue replication. You get a variant that might be breaking through, and the last thing we need is more variants. And the only way to stop it is to control the rate of infection.
Great, that's totally understood. Thank you so much.
Thank
Sure.
you. We have another question from Andrew Feather from WWMT in the western side of the state. Andrew, your question? Andrew? Nope, I can't hear Andrew. Let me, Andrew, if you could type your question into the chat, we can Oh, your mic's not working. We're gonna wait. Andrew's gonna type his message into the chat. Dr. Fishbain will ask it for him.
I don't fix microphones, sorry.
No, that's okay. Mhm. Appreciate your time. Andrew asks, with the CDC guidance on masks in schools and the Delta variant, do you think it's a time for the state to issue a mask mandate for schools?
Yeah, I really can't answer or address what the state should do or should not do. It's really not my role, but I will say that we as individuals can do what we need to do. I'm a big fan of masks. Yep, I took mine off when they said the vaccine works. Now with the Massachusetts data, I'm probably going to go back out and wear a mask. So we as individuals don't need really anybody to mandate anything. I think we can take some personal responsibility and just say, well, it's time to mask up. I'm just going to do it. I think that would be the best thing to do, is you as an individual make your best choice. We'll wait for the state to decide. And obviously the state has excellent public health resources and advisors. They're all very, very good. They've done a heck of a job over the last 2 years. So I will wait for those decisions, but we as individuals don't need to wait. We can do what we think is best for ourselves, our friends, and our family.
Thank you. Andrew, I hope that answered your question okay. Do we have any other questions? With that, I think we're done. Thank you so much, everybody, for joining us today at Beaumont Health. And thank you for your expertise, Dr. Fishbain.
Yep, thank you, everybody. Take care.
Thank you
Have a
all.
good
Great
day.
meeting. Appreciate it.
Have a good
Thanks.
day. Bye-bye.